welcome to the Deep Dive. Today, we're tackling a really significant phase after childbirth, the postpartum period, and the health considerations that come with it.
Right. It's a massive time of recovery, transition. The body just goes through incredible physiological changes.
Absolutely. And understanding those shifts and, the potential issues is just so crucial.
Exactly. And for this deep dive, we're leaning on a solid resource, the chapter on the postpartum period from Saunders Comprehensive Review for the NCLEX-PN Examination, the 7th edition.
So we're not just scratching the surface here.
No way. We're going deep. We're pulling out the essential nursing concepts, the key considerations, really digging into this material.
Okay, so our mission today, extract that core knowledge. We're talking immediate body adjustments, common discomforts, potential complications, the whole picture.
Right. We want to break it down clearly, step by step, so you get a really solid grasp of what's most important during this phase.
So if you're looking to really understand the intricacies of the postpartum period, maybe you're a healthcare professional, maybe just curious or supporting someone.
You're in the right place. We're going to unpack it all piece by piece.
All right, let's jump in. Physiological maternal changes after birth. First up, this process called involution. What exactly is that?
Involution is, well, it's basically the uterus rapidly shrinking back down to its non-pregnant size. Think of it shrinking back after being stretched out.
Okay, shrinking back, how long does that usually take?
Generally completed by about week 6 postpartum. And an interesting point for mothers who breastfeed.
Does that affect it?
It does. The oxytocin released during breastfeeding actually helps the uterus contract more effectively, so it can speed up involution a bit.
Fascinating. So how do we know it's happening properly? What are the signs?
Well, there are several things. The uterus itself loses a lot of weight. It goes from about 2 pounds right after birth down to only about 2 ounces by 6 weeks.
Wow, that's a huge change.
It really is. The lining, the endometrium, it regenerates. And the top part of the uterus, the fundus, you can actually track its descent. It moves down about 1 centimeter per day.
1 centimeter, like a finger width?
Yeah, roughly a finger width each day. And by about day 10 postpartum, you usually can't feel it anymore when you press on the abdomen.
Okay. And when clinicians are assessing this, what are they really looking for?
2 main things. Firmness is key. They check if the fundus feels firm. If it's soft or feels kind of boggy.
Boggy.
Yeah, that could mean uterine atony. The uterus isn't contracting well, which is a risk for bleeding. Gentle massage helps firm it up.
Okay. And the second thing?
Tenderness. If it's tender to the touch, that might signal an infection brewing. Also, mothers often feel afterpains.
Like the cramps.
Exactly, like menstrual cramps. They usually lessen after the first few days, though.
Right. Okay, another big postpartum change. Lochia. Can you explain what that is?
Sure. Lochia is the vaginal discharge after birth. It's mostly blood from where the placenta was attached, plus, tissue debris from the uterine lining that's shedding the decidua.
And it changes over time, right?
It does. There are distinct stages. First, for days 1 to 3, you have lochia rubra.
Rubra, red.
Bright red, yeah, like a heavy period. Then, from about day 4 to 10, it shifts to lochia serosa that's more brownish pink.
Okay, serosa.
And finally, around day 11 to 14, it becomes lochia alba. Alba means white, so it's a whitish or yellowish discharge.
And what's considered normal in terms of smell and amount?
The odor should be similar to normal menstrual flow, kind of fleshy. The amount should decrease day by day, though it's pretty normal to see a bit more if you're up and moving around.
How do providers get an accurate measure of the amount? Just asking about pads.
Asking helps, but the most objective way is actually weighing the perineal pads. You weigh a clean one, then the used one, subtract the difference.
Clever. Gives a real number.
Exactly. They also note how much time passed between changes. Weighing gives the most precise measurement.
Okay. What about the cervix and vagina? They went through a lot during birth.
They definitely did. The cervix also undergoes involution, starts shrinking back. The muscle tissue begins regenerating after about a week.
And the vagina.
The distension decreases for sure, but it's important for women to know that the muscle tone might not completely return to exactly how it was before pregnancy.
So things like Kegel exercises might be helpful there.
Very helpful, yes. Pelvic floor exercises are often recommended to improve that muscle tone.
Good point. Now, a question on many new mothers' minds. Periods. When does ovarian function get back to normal?
Yeah, that really depends on the pituitary gland getting back into its groove, hormonally speaking. For moms who aren't breastfeeding, periods usually start up again in about 1 to 2 months.
And for breastfeeding moms?
It typically takes longer, maybe 3 to 6 months.
Mm.
Some women who breastfeed exclusively might not get a period at all while they're lactating. That's called amenorrhea.
But, and this seems really important, does that mean they can't get pregnant?
Absolutely crucial point. No. You can ovulate, release an egg before your first period returns.
So breastfeeding isn't birth control.
Definitely not reliable birth control. You can conceive during that first postpartum ovulation, even without having had a period yet. Very important to discuss contraception.
Understood. Okay, let's talk about breasts. Big changes there, too.
Huge changes. For the first, say, 48 to 72 hours, the breasts secrete colostrum. That's that amazing early milk packed with antibodies.
Liquid gold, they call it?
Pretty much. Then, after the birth, estrogen and progesterone levels plummet. That drop signals the body, okay, time to make mature milk.
And that involves another hormone.
Right. Prolactin levels rise, and that's the main hormone driving milk production. Usually around day 3, moms feel their milk coming in. Breasts get noticeably fuller.
Which can lead to engorgement.
Yes, engorgement, that feeling of fullness, firmness, sometimes discomfort, often peaks around day 4. Happens whether you're breastfeeding or not initially.
How do you manage that discomfort?
Well, if you are breastfeeding, the best relief is frequent, effective nursing. The baby draining the breast relieves the pressure.
Makes sense. What if you're not breastfeeding?
Then the goal is the opposite. You want to avoid stimulating the nipples. A snug, supportive bra or a breast binder helps suppress milk production. Ice packs are great for relief. Mild pain relievers, too.
It resolves on its own.
For non-breastfeeding moms, yes, usually within about 24 to 36 hours.
Okay. Shifting gears a bit, urinary tract and GI system. What happens there postpartum?
In the urinary tract, you can sometimes see urinary retention difficulty emptying the bladder.
Why does that happen?
It can be due to loss of bladder tone or sensation from the birth itself, maybe anesthesia or meds, even just lack of privacy. But interestingly, the body also kicks into diuresis.
Diuresis. More
Or-
urination.
Exactly. Usually starts within 12 hours postpartum. The body starts shedding all that extra fluid accumulated during pregnancy.
And the GI tract. Besides being hungry, maybe.
Increased hunger is definitely common. Constipation can also be an issue. Hormones, less activity, pain meds might contribute. Usually, though, a bowel movement happens by day 2 or 3.
Hemorrhoids, too, I imagine.
Yeah, hemorrhoids are pretty common, unfortunately, due to pressure during pregnancy and pushing during labor.
Got it. Lastly, for the physiological changes, let's quickly cover vital signs. What's considered normal postpartum?
Okay, temperature might slightly increase, maybe up to 100.4 Fahrenheit in the first 24 hours. Often just mild dehydration from labor.
But anything higher needs checking.
Definitely. A persistent temp over 100.4 could signal infection. Pulse rate can actually decrease, sometimes down to 50 beats per minute. It's called puerperal bradycardia.
A slower pulse can be normal.
In the early postpartum phase, yes, but a pulse consistently over 100 could indicate blood loss, maybe pain or infection.
And blood pressure.
Should stay pretty close to the mom's normal baseline. A significant drop could mean hypovolemia, low blood volume, possibly from bleeding.
Okay. Respirations.
Usually no major change. But a noticeable increase in respiratory rate could be serious, think pulmonary embolism, or maybe uterine atony leading to blood loss. Needs investigation.
Okay, that covers the main physical shifts. Now let's talk about postpartum interventions. What are healthcare providers typically doing?
A huge part is ongoing data collection, those nursing assessments. So monitoring vitals regularly, temp, pulse, BP, respirations, and checking pain levels.
And checking the uterus, the fundus.
Absolutely. Checking its height, consistency, is it firm or boggy? And its location relative to the belly button. And crucially, always after the mom has emptied her bladder.
Why after emptying the bladder?
Because a full bladder can actually push the uterus up into the side and prevent it from contracting effectively.
Ah, okay. What else is assessed?
Lochia, definitely. Checking the color, the amount, how many pads, how quickly saturated the odor. Breasts are checked for engorgement, redness, or sore spots.
And the perineal area.
Yes, the perineum is checked for swelling, bruising. If there was a tear or an episiotomy, they look at how well it's healing. Any signs of infection? Are the edges coming together okay?
What about for moms who had a C-section?
For them, the abdominal incision site and any dressings are checked, looking for grainage, redness, signs of infection, making sure it's intact.
Fluid balance.
Yep, tracking intake and output is important. Encouraging frequent urination, assessing bowel function too, and getting the mom up and walking ambulation as soon as it's safe.
Why is ambulation so important?
It helps with overall recovery, stimulates circulation, helps prevent blood clots, which leads to another check assessing the legs for signs of thrombophlebitis.
Blood clots, right. What are the signs?
Things like redness, tenderness, warmth, or maybe swelling in one leg more than the other.
Got it. And there are specific interventions related to blood type and immunity, too.
Yes. If a mother is Rh negative and her baby is Rh positive, she'll get Rho D immune globulin Rhojam, usually within 72 hours.
To prevent issues in future pregnancies.
Exactly. It stops her from developing antibodies against Rh positive blood. Also, her rubella immunity is checked if she's not immune.
She gets the vaccine.
Usually, yes, before she leaves the hospital. But she needs to know to avoid getting pregnant for at least a month after the vaccine, sometimes longer based on provider advice.
Okay. Beyond the physical checks and shots, what else is key in postpartum care?
Oh, huge aspects are parent-newborn bonding and emotional well-being, observing interactions, encouraging that connection, and routinely assessing the mother's mood.
Looking for postpartum blues or something more serious?
Right. Screening for blues, depression, or rarely psychosis. And then there's client teaching a massive component.
What kind of teaching?
Newborn care skills are a big one. Bathing, feeding, diapering, giving the mom a chance to practice with support right there, reinforcing feeding techniques, whether breast or bottle.
And advice for the mother's own recovery.
Yes. Things like avoiding heavy lifting for at least 3 weeks, planning for rest periods, fatigue is real, discussing contraception options and timing.
And the importance of follow-up.
Crucial. Emphasizing that 4 to 6 week postpartum checkup and making sure she knows the red flag symptoms to report immediately.
Like what? What are those immediate report signs?
Things like chills, a fever developing, a sudden increase in bleeding or going back to bright red lochia after it had lightened, or persistent feelings of depression or hopelessness. Call the provider right away for those.
Okay, very clear. Now, many new moms face discomforts. Let's talk through some common ones and how to manage them. Afterbirth pains.
Yes, those uterine contractions we mentioned, they can be more intense for moms who've had babies before, or are breastfeeding, or had oxytocin, or a very stretched uterus.
What helps?
Mild pain relievers are often recommended, but it's always best to consult with the healthcare team for specific measures. Comfort measures like a heating pad can sometimes help too.
What about perineal discomfort? Especially with stitches from a tear or episiotomy.
Ice packs are key for the first 24 hours, really helps with swelling and numbing. Apply as prescribed.
And after the first day.
Warmth often feels better then. Sitz baths, those shallow warm baths, can be very soothing and promote healing.
And hygiene.
Meticulous perineal care is vital. Using a peri bottle with warm water to rinse after using the toilet. Patting dry gently. Analgesic sprays, if prescribed, can numb the area. Oral pain meds as needed.
Any restrictions with stitches?
Generally, yes. Avoid rectal suppositories or enemas if there are perineal sutures to prevent injury.
Makes sense. Breast discomfort from engorgement, we touched on this, but what are the comfort measures again?
A well-fitting supportive bra is essential. Wear it all the time, even sleeping. For breastfeeding moms, ice packs between feedings help swelling.
And heat before feeding.
Right. Warm compresses or a warm shower before feeding can help milk flow. And frequent nursing is the main relief. Pain relievers if needed, of course.
Okay. Constipation management, remind us of the key tips.
Fluids, fluids, fluids. Aim for at least 2 liters a day unless advised otherwise. High-fiber diet fruits, veggies, whole grains, and get moving ambulation helps.
And if that's not enough,
Stool softeners, laxatives, maybe an enema or suppository might be prescribed by the provider if needed.
in the emotional side of things, postpartum emotional changes can be really tough.
Absolutely. The most important thing is acknowledging those feelings. Approach with empathy, a caring attitude. Assess her support system, family, friends, partner. Encourage her to talk.
What else can help?
Help manage expectations around newborn care. Involve the partner and family in supporting her emotionally. And universal screening for depression and anxiety is standard now.
It's important to know the difference between the baby blues and more serious conditions, right?
Crucial. Postpartum blues are common mood swings, tearfulness, fatigue, anxiety, usually mild and transient, resolving in a week or two.
But postpartum depression,
That's more persistent and severe. Changes in appetite, deep sadness, trouble concentrating, guilt, lack of energy, maybe even thoughts of harming self or baby. Needs professional help immediately.
and postpartum psychosis.
That's a psychiatric emergency. A break with reality, confusion, delusions, hallucinations. Very rare, but requires urgent intervention. Any signs of PPD or psychosis need immediate reporting.
Okay, let's shift to nutritional counseling. What do postpartum moms need to know?
Needs vary, definitely. It depends on pre-pregnancy weight, ideal weight, activity level, and crucially breastfeeding status. Best to discuss specifics with a provider.
But general guidelines for breastfeeding moms.
They generally need more calories, an extra 200 to 500 calories per day usually. Fluid needs might increase too, and continuing prenatal vitamins is often recommended.
And non-breastfeeding moms.
Their calorie needs gradually return to pre-pregnancy levels. Still important to focus on a healthy, balanced diet and plenty of fluids for recovery.
All right, breastfeeding itself, a huge topic. What are some key interventions and advice?
Early initiation is best. Skin to skin right after birth if possible. Offer the breast as soon as mom and baby are stable.
And support is key early on.
Absolutely. Stay with the mom during those first feedings until she feels secure. Use assessment tools like LATCH to check effectiveness.
LATCH. Remind us what that stands for?
Sure. L is for latch, A for audible swallowing, T for type of nipple, C for comfort of the mother, and H for holder position. It's a quick assessment.
Got it. Are there common physical things moms notice when starting breastfeeding?
Yes, those uterine cramps, the afterpains, can be more noticeable during nursing because of the oxytocin release.
What about breast care?
Good hand hygiene is number one. Wash breasts once daily, usually just with water. Soap can be drying.
And managing engorgement and cracked nipples if they happen.
For engorgement, frequent feeding, warm packs before, ice packs between, massage. For cracked nipples, air dry after feeding, rotate baby's position, ensure a deep latch onto the areola, not just the nipple.
Broad recommendations.
Supportive, well-fitted, avoid underwires as they can block ducts, breast pads for leaking milk.
And reminding moms about their own needs.
Yes. Increased calories, fluids, continuing vitamins as prescribed. Also, letting them know what normal breastfed baby poop looks like, light yellow, seedy, watery, frequent.
Important info. What about medications or diet?
Caution with all meds, even over-the-counter check with provider first. Some find avoiding gassy foods or lots of caffeine helps baby's fussiness.
And contraception again.
Estrogen-containing pills aren't usually recommended first line as they might affect milk supply. Progestin-only methods are often preferred. And remember, baby sets the feeding schedule.
Can you quickly walk through the basic steps a mother should follow for a feeding?
Okay. Wash hands, get comfy, start on the last breast used, tickle baby's lower lip to get a wide open mouth, guide nipple and areola deep into the mouth.
How long per side?
Nurse about 15-20 minutes per breast or until baby seems done. Listen for swallowing, break suction gently, finger in the corner of the mouth, or press chin down.
And booping.
Burp after the first breast, offer the second. Burp again after the second breast, even if they didn't take much.
Okay, good overview. Now let's pivot to potential complications.
Yeah.
What should providers be watching for?
Cystitis, a bladder infection is one. Encourage fluids, frequent voiding if symptoms arise.
Like burning or urgency?
Exactly. Get that urine sample for culture before starting antibiotics. That's key.
Another one is hematoma. What's it again?
A collection of blood in the tissues. Can be internal or external, like a vulvar hematoma. More common after forceps or vacuum delivery or vessel injury.
I think it can be serious.
Potentially life-threatening if it's large and leads to significant blood loss.
What are the warning signs of a hematoma?
Severe perineal or rectal pain often feels out of proportion. A feeling of pressure. You might see or feel a sensitive, bulging, discolored mass. Difficulty urinating is common too.
And signs of blood loss?
Yes, potentially decreased hemoglobin hematocrit. Signs of shock like pallor, fast heart rate, low blood pressure.
How are hematomas managed?
Depends on size and symptoms. Monitor vital signs closely. Assess pain and pressure. Ice packs are usually first line. Pain meds. Monitor INO, encourage fluids, maybe catheterize if needed.
What if there's significant bleeding?
May need blood products, monitor for infection, possibly antibiotics. Larger ones might need surgical incision and drainage.
Okay. Uterine atony, we mentioned this earlier as a cause of bleeding.
Yeah.
Remind us what it is.
It's when the uterus fails to contract firmly after delivery. Those muscle contractions are what clamp down on blood vessels at the placental site. Without them,
Risk of hemorrhage.
high risk, yes. The uterus feels soft, boggy on palpation instead of firm.
And the immediate action.
Massage the fundus, gently but firmly through the abdomen until it firms up. Also, empty the bladder void or catheterize.
And if that doesn't work quickly?
Notify the provider immediately. Hemorrhage risk is significant.
Let's talk more about hemorrhage. It's defined as
Typically, 500 millihal blood loss after vaginal birth or 1,000 millihal after C-section. But really, any bleeding causing instability is a hemorrhage.
early versus late.
Early is within the first 24 hours. Late is after 24 hours up to 6 weeks postpartum.
What are the main causes or risk factors?
Uterine atony is the #1 cause of early PPH. Others include lacerations, hematomas, retained placental fragments,
Risk factor.
history of PPH, placenta previabruption, overdistended uterus, twins, large baby, polyhydramnios, infection, multiple prior births, long labor, operative delivery. Quite a few things increase risk.
What are the critical signs a nurse needs to spot fast?
Persistent heavy bleeding, soaking a pad in under 15 minutes is a huge red flag. Restlessness, anxiety, increasing pulse rate, decreasing blood pressure, cool, clammy skin, paleness, feeling weak, lightheaded, short of breath.
If hemorrhage is happening, what are the absolute priority nursing actions?
Okay, first, call for help. Notify the RN immediately. Stay with the patient. RN notifies the provider.
Then what?
If the uterus is boggy, massage the fundus. Position the patient side lying or elevate right hip. Elevate legs 30 degrees. Oxygen 8 to 10 liters via non-rebreather mask usually.
Monitor vitals continuously.
Absolutely. Frequent vitals. Prepare to give uterotonic meds, oxytocin, methergine, hemabate, cytotec as ordered. Get IV fluids going. Usually need 2 lines. Prepare for blood products.
Like a catheter.
Yes. Insert an indwelling catheter to monitor urine output. Closely shows kidney perfusion. Assist with any emergency meds or procedures. Document everything.
And the cardinal rule.
Never leave an unstable patient. Assess quickly, massage if atonic, position, monitor, implement orders fast.
Critical steps. Okay, let's move to infections postpartum. General signs.
Fever, 100.4 F or higher after the first 24 hours. Chills, loss of appetite, pelvic pain, foul-smelling discharge, elevated white blood cell count too.
Standard nursing care for infection.
Monitor vitals, especially temp. Promote comfort, position for drainage, like semi-foulers. Keep warm if chilled. Usually no need to isolate baby unless specific risk. Hand hygiene is paramount.
Diet and fluids.
High-calorie, high-protein diet. Encourage lots of fluids. 3 to 4 liters safe, okay? Frequent voiding. Monitor INO. Give antibiotics as prescribed. Monitor cultures.
Okay, what about mastitis specifically? Breast infection.
Right. Usually affects breastfeeding moms, maybe 2-3 weeks postpartum, but can be any time. Look for localized heat, swelling, redness, pain in one area of the breast.
Other signs.
Tender lymph nodes in the armpit on that side. Fever, flu-like symptoms, aches, fatigue.
How's mastitis managed? Can mom keep breastfeeding?
Yes. Continuing to breastfeed frequently is actually key to resolving it, helps drain the affected area. Good hand hygiene. Warm compresses before feeding, cool after. Supportive bra, pain relievers.
And antibiotics.
Usually needed to treat the bacterial infection. Finish the whole course. Rest and fluids are important too. If nursing is too painful, pump or hand express regularly.
Got it. Endometritis infection of the uterine lining. Signs.
Chills, fever, increased pulse, poor appetite, headache, backache, prolonged severe afterpains, tender enlarged uterus, foul smelling, maybe reddish-brown lochia, sometimes ileus, elevated WBC count.
How is endometritis treated? Interventions.
Monitor vitals. Semi-Fowler's position helps drainage. Private room often. Hand washing. Contact precautions if needed. Monitor INO. Push fluids. 4V antibiotics are crucial. Comfort measures. Maybe oxytocics for uterine tone.
Pulmonary embolism. The blood clot traveling to the lungs. Very serious. Key signs.
Sudden shortness of breath. Sudden chest pain. Often sharp, worse with breathing, rapid heart rate, cough, maybe bloody, lung crackles, feeling of anxiety, impending doom.
Immediate actions if PE is suspected.
Oxygen first, high flow via mask, elevate head of bed, frequent vital signs, monitor respiratory status very closely, look for worsening distress, low oxygen, cyanosis.
What else?
Assist with 5V fluids, prepare to give anticoagulants like heparin, may need to assist with clot-busting meds, thrombolytics if ordered. Call for help immediately, this is an emergency.
Okay, subinvolution uterus not shrinking back properly. Signs.
Uterine pain or tenderness when palpated. Uterus feels larger than expected for the postpartum day. More bleeding than normal or bleeding persists longer. Monitor vitals, fundus, bleeding. Elevate legs. Encourage frequent voiding. Check hemoglobin hematocrit. May give meds like methylargonavine to help the uterus contract.
And finally, thrombophlebitis. The blood clot in a vein with inflammation. Risk factors again.
Increased clotting factors postpartum, less mobility, vessel trauma. Early ambulation helps prevent it.
Different types,
Yeah.
right? Superficial versus deep.
Yes. Superficial, palpable hard cord, tenderness, warmth, redness along a surface vein. Femoral DVT, malaise, chills, fever, maybe diminished pulse, shiny white skin, pain, stiffness, swelling in the leg. Pelvic DVT can be subtle, maybe severe chills, big temp swings. PE might be the first sign.
Key interventions for thrombophlebitis.
Depends on location. Check legs for edema, tenderness, warmth, varices. Bed rest might be ordered initially for DVT. Elevate the affected leg. Use a bed cradle.
And crucially,
Never massage the affected leg. Could dislodge the clot. Monitor closely for PE signs. Warm packs for comfort. Elastic stockings might be used. Pain meds, maybe antibiotics.
anticoagulants for DVT.
Yes, often IV heparin initially for femoral or pelvic DVT. Education is vital, no massage, avoid crossing legs, proper stocking use, importance of anticoagulant follow-up.
The chapter also covers perinatal loss, a very sensitive topic.
Incredibly sensitive. It covers miscarriage, stillbirth, neonatal death, therapeutic abortion, but also the grief with preterm birth, anomalies, adoption. Care needs to be so individualized, respectful of culture and beliefs.
What are the core nursing actions?
Therapeutic communication, active listening, giving time and space to grieve, offering spiritual support chaplain, etc., discussing options, seeing holding the baby, rituals, funeral info. Memory boxes are often offered, footprints, photos,
And practical support.
a private room if possible. Using a special door card per hospital policy for awareness and confidentiality. Following protocols carefully, just being present and compassionate.
Lastly, the Saunders chapter ends with practice questions. What's their purpose?
They tie everything together, help you apply the knowledge recognizing complications like hematoma or PE from symptoms, knowing self-care for mastitis, understanding breastfeeding education, PPH management, normal assessments.
And they provide rationale.
Yes, detailed rationales for why the right answer is right, and often test-taking tips too, really help solidify understanding and critical thinking.
Okay, so we've really done a deep dive into this chapter. We've covered the normal physiological changes, the essential assessments and interventions, common discomforts in management, nutrition, breastfeeding.
And a pretty thorough look at potential complications, signs, symptoms, and those crucial priority actions. Cystitis, hematomas, atony, hemorrhage, infection, mastitis, endometritis, PE, subinvolution, thrombophlebitis, and perinatal loss care.
We aim to extract that core knowledge, unpack it all clearly. Hopefully we've achieved that mission.
Yeah, it's a lot, but broken down, it provides that solid foundation for understanding this critical time.
So, thinking about everything we've discussed, the rapid physical changes, the emotional shifts, the potential risks, what do you think is truly the single most crucial aspect of care and support during the postpartum period? Is it physical recovery, emotional well-being, education, something else entirely?
That's a tough one. It really highlights how interconnected everything is. It's such a vulnerable time that demands that holistic attention, doesn't it? Looking at the whole person, the whole family.
A great point to ponder. Thank you for joining us for this deep dive into the postpartum period. We hope this detailed exploration has been valuable for you.